There is a surgical procedure that's performed here in the United States and worldwide, but in the United States, it's performed at a rate up to 700,000 times per year, costing an estimated $4 billion annually. And a major new study just came out showing that not only is this surgery worthless, it's actually worse than worthless because the outcomes of having the surgery are worse than if you didn't have the surgery at all. So you probably guessed what I'm talking about based on the title of this video, but yes, I'm referring to meniscus surgery in the knee. And the results are kind of shocking. Researchers followed patients for 10 years after meniscus surgery and found that patients who underwent fake surgery did just as well and over time did actually better than people who got the real surgery. And when I say fake surgery, yes, I mean the researchers had these patients go under anesthesia and they were told that they had surgery, but really they didn't. At 1 year, post-surgery or post-fake surgery, there was no difference between the groups. 2 years, still no meaningful difference. 5 years later, the group that had the surgery started showing more signs of osteoarthritis in their knees. And now, this new study just came out 10 years after the surgery. In the same group of people, the surgery group appears to have more symptoms, worse function, and more additional surgeries than the group who had the fake surgery. So if you, or somebody that you know, have been told that you have a meniscus tear, before you let someone inject your knee with something or quote unquote fix your knee with surgery, you need to hear this, you need to watch this video, because there's a very good chance that your MRI has been misunderstood or misinterpreted. Now, before we go any further, I want to clarify something important. We're not talking about, the 19-year-old soccer player whose knee locked after like a violent twisting injury. I'm talking about what we see all the time on the MRIs of knees in adults over 30, right? That kind of meniscus pathology we'll talk about often shows up after gardening or walking downstairs or CrossFit or pickleball, or honestly sometimes for no reason at all. So let's start with the most important thing patients are never told. Meniscus abnormalities on MRI are extremely common in people with absolutely no knee pain. Seriously, a recent study using high-resolution 3T MRI in 230 knees of 115 pain-free sedentary adults with a median age of 44 found 30% of the knees had tears in their meniscus, including complex tears and even bucket handle tears, which are tear types traditionally considered surgical indications. Now remember, these were people with absolutely no pain. And in athletes, the number goes even higher. A systematic review of 14 other studies, including about 300 pain-free athletes, with an average age of only 31, found 31% of them had meniscus pathology on MRI. And a systematic review of the relationship between meniscus pathology on MRI and pain in knee arthritis found no association between meniscus tears and pain severity or pain progression. So what I'm saying here is that if someone has knee pain and they get an MRI, there's actually a really good chance that that MRI will show a problem in the meniscus. However, there is such a high prevalence of these findings on people without pain, there's no way to prove that your pain is actually coming from the meniscus. Another study used high-resolution MRI scanners on healthy adults with no symptoms whatsoever, and 97% had quote-unquote abnormalities. 97%. And about 30% had meniscus tears, despite feeling perfectly fine. And think about how crazy this is for a second. If almost everybody over a certain age has abnormalities, then maybe abnormal starts becoming pretty normal. And this is where things can become dangerous psychologically, because when a patient hears words like tear or degeneration or bone on bone or wear and tear, the brain often interprets that as my knee is damaged, I'm fragile, I should stop moving, and that can create something called the nocebo effect. The opposite of the placebo effect, where you're told that something's going to make you better, a nocebo effect actually makes you feel worse. So negative expectations can actually amplify pain and disability. And we know from research that alarming MRI language can increase catastrophizing, fear, and poor outcomes. So please understand, an MRI finding does not automatically explain your pain. And it definitely does not mean you automatically need surgery, right? So let's talk about the study that completely changed this conversation, the one that I talked about at the beginning of this video. It's called the FIDELITY trial. And this is one of the most important orthopedic studies of the last decade. Researchers in Finland took patients with knee pain and MRI confirmed degenerative meniscus tears. And everyone went into the operating room. Everyone got anesthesia. Everyone got incisions. But only half the people actually received real surgery and half the people received fake surgery. The surgeons simulated the procedure, but they didn't actually trim the meniscus. And neither the patients nor the evaluators of the research knew who got which procedure. So this is what's called a double-blind placebo-controlled trial, which is about as rigorous as medical research gets. And the results, as I said, at 1 year, both groups improved substantially, but there was no meaningful difference between the real surgery and the fake surgery. The sham surgery worked just as well. And maybe you're thinking, well, maybe they just needed more time. No, 2 years later, there was still no meaningful benefit from the surgery. And this part is important. Even with patients with clicking or mechanical symptoms, they did not consistently benefit more from surgery. But then things got even more interesting. At the 5-year follow-up, the surgery group started showing more osteoarthritis, which makes sense, right? If you take some cushioning out from the knee, there's less there to protect it, and arthritis might ensue. But now, just recently, the 10-year follow-up suggests something even more concerning. The patients who had the real surgery 10 years ago, they now have more symptoms, worse function, more arthritis progression, and more additional surgeries. And that's a massive deal, obviously, because for decades, the assumption was if we clean up the torn tissue, patients will do better. But this research suggests that removing meniscus tissue can actually create problems over time. Duh. The meniscus is a shock absorber, right? So if you remove portions of it, you may reduce the knee's ability to distribute load. Now, to be fair, there are situations where surgery absolutely makes sense, right? A truly locked knee, certain traumatic tears, some root tears, some bucket handle tears. So this video is not like all surgery is bad. This video is be cautious about assuming that your MRI abnormalities explain your pain. And the FIDELITY trial isn't some like weird outlier. Multiple high-quality studies have found very similar results. The METEOR trial, the ESCAPE trial. We could go through all these studies that show this, but thankfully in 2023, a study published in the Journal of the American Medical Association did this for us. They took the data from 5 trials where they compared real surgery to fake surgery, and they found no improvement compared to sham surgery. Knee osteoarthritis, patellofemoral pain, and meniscus tears are common causes of knee pain. They can be diagnosed clinically, right, which means not necessarily with MRI, and they can be associated with significant disability. But they say the first-line treatment for each condition consists of conservative management with a focus on exercise, education, and self-management. Which brings us to what should actually be getting done for these conditions. Exercise. Not because it's flashy, not because it creates dramatic MRI changes, not because it magically repairs the meniscus, but because over and over again, patients tend to improve with it. Strength improves, confidence improves, pain often improves, function improves, and more importantly, people improve without removing part of the meniscus. And that's a huge distinction, right? Because surgery is subtractive. You literally are removing tissue from a shock absorber inside the knee. Exercise does the opposite. It builds capacity. And the evidence is actually really strong. A massive Cochrane review looked at 139 trials involving more than 12,000 patients and found that exercise significantly improves pain and physical function in knee arthritis. Another article in the New England Journal of Medicine confirmed that exercise reduces pain, improves function, and most importantly, does not appear to accelerate degeneration or make the condition worse. And because of all of this evidence, modern clinical guidelines now recommend that most patients with symptomatic degenerative meniscus tears start with physical therapy or rehabilitation as a first-line treatment, often for at least 3 months before even considering surgery. And honestly, this makes sense if you stop thinking about the knee as just damaged tissue and start thinking about it as a living, adaptable system. Knees are made of muscles, tendons, bones, synovium, nervous system. Movement confidence, load tolerance are important. Exercise improves strength, joint capacity, blood flow, pain modulation, and most importantly, it teaches people that the knee is still capable. And I think this is one of the biggest mind shifts that patients need to hear. The goal is not to create a perfect MRI. The goal is to create a capable knee. Another treatment that's showing a lot of promise is shockwave. For example, this recent paper on shockwave for degenerative meniscus tears shows significant changes in the meniscus that you can actually observe on the MRI and symptomatically due to the use of shockwave. So this study reported that extracorporeal shockwave therapy improved the condition of the meniscus by reorganizing collagen and reducing swelling. And they also reported patients felt significant pain relief within just 3 weeks of starting treatment. And they also said no serious side effects were reported and the treatment was well tolerated by all patients. So unfortunately, here in the US, a lot of people have never heard of shockwave. If you're watching this video and you live locally where I am, we have one in the office. If you're somewhere remote watching this, you should probably look into someone in your area who has shockwave combined with exercise. All right, so what about injections? And this is where things get a little bit controversial again. Corticosteroid injections can absolutely reduce pain short term, no question. But longer term data is much less encouraging. One major randomized controlled trial found that repeated cortisone injections led to greater cartilage loss without better pain relief compared to just placebo like saline injections. Other research has associated corticosteroid injections with greater osteoarthritis progression on MRI. So I'm not saying corticosteroids should never be used. There may absolutely be situations where short-term symptom reduction is helpful, but patients need to understand the trade-offs. And so what about other injections like PRP, right? Platelet-rich plasma. When researchers perform high-quality placebo-controlled trials, the results are just not impressive. And when I say high-quality trials, I mean trials where they don't compare PRP to steroid injections because, as we already saw, steroids seem to actually have negative consequences. So if you want to compare a treatment to something that has a negative effect, of course your treatment is going to look great. But unfortunately, there are 0 trials that have looked at PRP versus saline injections, like a placebo for meniscus tears. But if you compare PRP to just injecting a placebo like saline for knee arthritis, not necessarily meniscus tears, but knee arthritis, the results aren't good either. The large RESTORE, is what it was called, trial, published in Journal of the American Medical Association, found PRP was no better than saline placebo injections for pain or cartilage preservation at 12 months. But again, just like we saw with steroid injection studies, the group that got PRP injections had significantly more areas of cartilage thinning. Now that doesn't mean that PRP can never help, but it does mean the evidence is nowhere near as definitive as like social media marketing sometimes makes it sound. So here's the big takeaway. I want people to understand this. A meniscus tear on MRI does not automatically mean that your knee is damaged. It does not automatically mean you need surgery, and it definitely does not mean that your future of your knee is hopeless. In fact, many people improve dramatically with time and education and exercise, gradual loading, and simply understanding that the body is far more capable and adaptable than what they were originally led to believe. So if your MRI says degenerative tear, arthritis, or cartilage degeneration, wear and tear, please understand those findings are part of a normal aging process. Just like wrinkles as we age, but these are wrinkles on the inside. And ironically, Sometimes the scariest part of that diagnosis isn't the MRI finding itself, it's the story that the patient starts believing about themselves afterward. So your knee is probably stronger than you think, and for many people, the path forward is not less movement, it's smarter movement. Thanks for watching.